Good morning and good evening, fellow doctors and colleagues. For the fifth portion of Dr. Sheng-Po Hao retirement virtual webinar, we are honored to introduce Professor Chung Hwan Baek as our invited speaker. Professor Chung Hwan Baek graduated from Hanyang University and completed his internship and residency in Hanyang University. Professor Chung Hwan Baek is currently working as a professor of Department of Otolaryngology, Head and Neck Surgery at Chung Hwan University School of Medicine. He was also the founding editor-in-chief of Clinical Experimental Otolaryngology. Today, Professor Chung Hwan Baek's presenting topic is the evolution of tongue cancer treatment. Please give a round of applause to welcome Professor Chung Hwan Baek.
Hi, everybody. I'm very happy to have a lecture with you for the ceremony of Dr. Hao's Peter's retirement. It's very nice to see you on the web. Peter, congratulations for your retirement. It's a new beginning of a new life. Okay.
Thank you.
Good morning, everybody. I'm Chung Hwan Baek from Korea. Peter and I first met 19 years ago in 2005 at my annual workshop in Korea, and our friendship continues to this day. Today, I sincerely congratulate on Peter's retirement. Peter, this is the right time for you to look back proudly at yourself on the great mountain you have climbed up in your life so far. Looks very young, 19 years ago. Today's my talk is about tongue cancer. Although each country has different incidence rate, the first incidence rate is India, and this is Korea and the United States. Furthermore, the incidence has increased, especially young people in many countries. In Korea, there has been 7.7 increase since 1999, especially among people in their 20s and 30s. Up to now, surgical treatment is still the main therapeutic option for tongue cancer. This means the surgeon has an important role in the treatment of tongue cancer. I have tried to modulate prognostic factors for better oncologic results and the quality of life of tongue cancer patients as a surgeon. In that aspect, AJCC TNM staging manual and NCCN guidelines have been the most powerful references to me from the beginning of my career. The first AJCC edition was published in 1977. Recent 8th edition became effective from January 2018. For T-staging, the 8th edition excluded deep muscle invasion from T4A. On the other side, a DOI of tumor was integrated as a major element in defining T-staging in 8th edition. AJCC emphasizes DOI is not tumor thickness and defines DOI on the pathologic specimen very clearly and briefly. DOI evaluation needs both intact mucosal basement membrane around the tumor and to measure the distance on the pathologic specimen. I will talk about tumor thickness and DOI more detail. In 1994, Klingman reported elective neck dissection benefit over observation-only patient groups, especially the patient with a tumor thickness 4 millimeters. On disease-free survival, from those days up to AJCC version, definition of tumor thickness and DOI were ambiguous and often used interchangeably in many studies. In 1998, MD Anderson Group also prospectively reported importance of elective neck detection to detect occult nodal metastasis in T1 cancer with depths of muscle invasion over 4 millimeters. They expressed depths of muscle invasion instead of DOI. In 2005 review paper, tumor thickness and DOI of oral cavity cancers are important factors for the progression of nodal metastasis. They suggested consensus and to develop therapy protocols that include tumor thickness. They used the term tumor thickness instead of DOI. That means many studies on the review used tumor thickness rather than DOI. Incorporation of DOI in eighth edition was based on the recommendations of International Consortium for Outcome Research in Head and Neck Cancer 2014. ISOR proposed a new T-staging model by analyzing data from 11 international comprehensive cancer centers, then validated using data from Memorial Sloan Kettering and Princess Margaret Hospital before publication of the new staging manual. The reason why ICOR recommended T-staging model with optimal DOI cutoff of 5 mm in T1 and 10 mm in T2 for cancers, instead of a cutoff 3 mm or 4 mm, is that they followed Groom's tenets for proper staging system: hazard consistency, hazard discrimination, balance between the groups, and high predictive ability. In this review table, we can see more stringent DOI cutoff values. However, using such a stringent cutoff may result in a much higher percentage of previous T1, T2 cases being upstaged to T3. Then overtreatment for increased T3 could be performed, and increased morbidity and mortality from unnecessary adjuvant therapy or radical neck dissection could happen. After 8th edition release, another issues were raised. Another issue is DOI on the pathologic specimen. For example, DOI cannot be measured in positive dim margin cases and biopsy-only cases. Also, DOI does not present pathologic features such as PNI and RI were found apart from the dim margin. Recently, Sloan Kettering Group compared DOI and tumor thickness in early tongue cancers with a comparable result in both groups. They proposed more to replace a complicated DOI with a tumor thickness in the PT staging system. I think this issue should be continuously studied in the future. Next, I will talk about surgeon's role to detect occult metastasis. Early-stage oral tongue squamous cell carcinoma had a rate of 24.4% for occult nodal metastasis. Recent meta-analysis of early tongue cancer, elective neck dissection can significantly reduce regional nodal recurrence in CT1, T2 angular oral tongue cancers than observation-only group. Even though elective neck dissection provides better prognosis than observation in early clinical node negative tongue cancers, many surgeons still adopted observation to avoid the disadvantage of elective neck dissection. Unnecessary overtreatment is 75%, and the surgical morbidity and sequelae, especially shoulder function. To compensate disadvantages of elective neck dissection, sentinel lymph node biopsy in oral cavity cancer have continuously performed after first report sentinel lymph node biopsy in head and neck cancer in 1996. In the development history of sentinel lymph node biopsy, head and neck squamous cell carcinoma, the first international conference held in Glasgow 2001 is a very important starting point of sentinel lymph node biopsy in head and neck cancer. Then another important point of sentinel lymph node biopsy is the prospective multi-institutional trial by Dr. Sivantos 2010. In our institute, we launched the sentinel lymph node biopsy validation trial from 2002 and the application trial for 2004 with this design. After peritumoral submucosal injection of radioisotope, sequential node mapping could be done with early dynamic and delayed static images. We used only handheld gamma probe to detect the sentinel lymph node. We could report our first successful validation result in sentinel lymph node biopsy only group in 2006. Due to many successful data of sentinel lymph node biopsy, 2014 version of NCCN guideline for the first time recommended sentinel lymph node biopsy to detect occult metastasis in CT1, T2 cancers. We reported second our long-term oncologic result between validation and application group 2015. Our data showed high false negative and acceptable outcomes between two groups with a stringent strategy of follow-up and salvage treatment. Meta-analysis in 2017 revealed sentinel lymph node biopsy effectively predict the status of regional lymph nodes in clinical node negative early tongue cancer patients. Detection rate was 98% and NPV of sentinel lymph node biopsy was 0.96. In our recent third data, sentinel lymph node biopsy showed comparable oncologic outcome with elective neck dissection in CN0 tongue cancer patient. 2024 NCCN guidelines mentioned sentinel lymph node biopsy has been shown to be feasible and effective in patients who have high risk of metastasis based on tumor size and depth with a review of recent meta-analysis 2021. I'm happy our previous two reports contributed such an evidence. New guideline recommends sentinel lymph node biopsy or DOI as the best predictor of occult metastatic disease, and following stringent cutoff value of 3 millimeters, elective neck dissection should be strongly considered in tumors with a depth of greater than 3 millimeters. Other factors about the location of the tumor field, imaging, clinical judging must be considered in tumor less than 3 millimeter depth. Even though sentinel lymph node biopsy have been performed on the largest number of patients with comparable result to elective neck dissection, however, technically demanding procedure using radioisotope. Other trials in progress to overcome the conventional sentinel lymph node procedure. Next, I would like to talk about surgical margin, the most important factor that surgeon can be involved in. In 2007, Canadian colleagues reported importance of surgical margin on oncologic survival and emphasized the need of standard definition for the close margin for further evaluation. Even some investigators suggested wide margin more than conventional 1 centimeter surgical margin due to common involved surgical margins even in early tongue cancers. Next, we tried to get a deep clear margin over 5 millimeters after bisecting the mid portion of the tumor and identifying the deepest portion of the tumor. This new concept approach provides adequate deep resection margin for early stage tongue cancers with better local control than conventional envelope resection. It can decrease re-resection and the necessity of adjuvant radiotherapy. Sloan-Kettering Group 2017 also analyzed 381 cases of oral tongue cancers and reported local recurrence-free survival was significantly affected only with the surgical margin of less than or equal to 2.2 millimeters than 5 millimeters. We also analyzed 2017 at our clinical data to determine the effect of closed surgical margin less than 5 millimeters on local recurrence. Less than 5 millimeter margin showed significant risk factor for local recurrence only in advanced oral cancers, but not in early stage cancers with a microscopic tumor extension was not beyond 3 millimeters in T1 tumors. Thus, the extent of surgical safety margin can be redefined according to the primary tumor size. On the other hand, debates on clear and close margin are actively underway. 2018 NCCN guideline defines a clear margin over 5 millimeters, close margin less than 5 millimeters, arbitrarily without reasonable evidence. 2020, Australian colleagues reported to achieve over 5 millimeters historical margin is still needed to maximize local regional control and overall survival. In 2023, multi-center retrospective study of 564 patients revealed local recurrence with a cutoff values of 3.3 millimeters for horizontal distance and 3.1 millimeter for vertical distance. 2024 NCCN guidelines mentioned with some different stance. At this time, there is no universal definition of what constitutes a clear and or close margin. As the controversy over clear margins in tongue cancer continues, surgeons may be confused about obtaining clear margins in actual surgery. I hope the various multi-center prospective studies would be conducted for more precise surgical cutoffs with other evaluation methods in the near future. Before retirement, I had performed 1,014 oral cancer surgeries. Of these, my biggest concern was the tongue cancer. These graphs are showing the grade card of my career in treating oral cancer patients. It looks good. I will summarize my talk. Try to find out surgeon's perspective and active role to improve oncology prognosis and quality of life of the patient with a thorough understanding of the background and the inside meaning of serial versions of AJCC staging system and the NCCN guidelines. Do the best to manage the occult metastasis in early clinical node negative tongue cancer patients, even in different surgeon situations. Surgical margins must be determined thorough, detailed pre- and intraoperative evaluation of many prognostic factors to avoid the tumor involvement in the first resection and secure adequate margin. Currently, there are different opinions on the appropriate cutoff values from the tumor. But in clinical practice, it would be realistic to perform surgical resection with a sufficient surgical resection margin rather than pursuing a narrow margin to avoid positive and so-called closed margin to reduce the unnecessary second resection, postoperative radiotherapy, and worse prognosis. We're still waiting for other methods to detect appropriate margin intraoperatively. This picture is Dr. Sheng-Po Hao's online lecture on my retirement ceremony at August 2022. Peter, congratulations again for your retirement and enjoy your new happy start with your family. Thank you very much, everybody, for your attention.
You are mute. Peter, you are mute.
Thank you very much of Professor Chung Hwan Baek, very comprehensive talk about the evolution of tongue cancer treatment. Now we open up to the floor to if any colleagues have any questions or any discussions.
No question
Well,
is better.
Well, very, very nice talk, Chung Hwan Baek. Thank
you.
you for such a wonderful talk. Actually, I have to confess, this is the most wonderful talk I have ever heard on the management, the evaluation of tongue cancer treatment. I think you really prepare something, and not only review of the literature, but also add with your own data, which is excellent.
Thank
And
you.
so I really learned a lot from you, and I believe your talk would be a very good resources for the young surgeons like my son Peter. I think Peter, you should learn from Professor Chung Hwan Baek. All the points he made is very critical, and so that's a surgeon's experience based on his 20-30 years of treatment of oral cavity cancer and tongue cancer. So thank you so much, Chung Hwan Baek, for supporting me and supporting for this event. And I really thank you. And there's a question from the audience that to evaluate margin intraoperatively, do you send both main specimen and samples from the bed for frozen section? And Chung Hwan, you want to address this? So how you evaluate your margin? You take margin from the specimen, or you take samples from the surgical bed?
Did you mean the surgical margin? How to detect the surgical margin intraoperatively? Yes. Oh, yeah. Usually the by frozen section, frozen biopsy, and I send specimen like modified Morse surgery specimen. So some Japanese doctor reported a very nice result, and with a similar my method, but he recommended some margins. Definitely cut the outer margin, because the pathologist has some confusion for the orientation of the specimen. So I asked the pathologist, is there some dysplastic or margin at this small specimen, the whole round? And so I send the whole specimen for the frozen biopsy to detect the whole round peripheral margin and some center of the deep margin. But I cut the peripheral, most the peripheral area with the linear status. So I asked my pathologist, is there any tumor in piece 1 and piece 2, piece 3, piece 4, and the deep margin? And we can have an answer. Oh, there is no tumor at your specimen, because it's easier for the pathologist to mention about the tumor is positive or negative at the specimen.
Thank you, Chung Hwan. Let me share with you my own experience. When I did fellowship with Dr. Miles in Pittsburgh, I think at that time in Pittsburgh, 1992, 1993, Dr. Miles asked the pathologist to come into the operation room when he removed the tumor, and the pathologist would decide which portion of the specimen, the samples, should be taken from the surgical bed or just from the surgical specimen. So the pathologist come into the operating theater to take the samples from the either the specimen or the surgical bed. But clinically, in clinical practice, it will be very, very difficult. But now in my practice, I find that it would be best for us to take the whole thing for a small tumors. T1, T2 tongue cancer, we could reset and block and send the whole specimen for pathologist, and the pathologist will examine the tech samples from the cancer and then evaluate the margin. But for more advanced cases, such as T3 or T4 with surrounding soft tissue or bone invasion, etc., it will be very, very difficult to take the margins from the surgical specimen. So sometimes the surgeons might just take the surgical margins on the surgical bed. I think that's a modification on the clinical practice. I believe if we take samples from the tumor itself, it might best represent the surgical margin. But in clinical practice, it might be very, very difficult to do that, especially in advanced margins. And I don't know if Fredo or some others would have or Peter, do you have, as a young surgeon, do you have any comment on this? Or Fredo, you want to comment on our practice and Chung Hwan Baek practice as well? Fredo.
Yes. Okay. Thank you. Thank you, Peter. Again, Dr. Baek, that was a very beautiful lecture and thought-provoking, actually, because we really still have to know a lot more. But my practice is that I resect more or less 1 to 1.5 centimeter all around the lesion, and then we have we definitely put markers to show where the anterior, the posterior, and the lateral is, and that's where the pathologist would take the specimen for the margin. Now, if any one of it becomes positive, at least we know where it is, and that's where we add an additional margin in the area. So we have a block that we put the specimen there so that the pathologist is very well oriented as to where the specimen was taken from. So at least they are guided well as to where where it's positive, where it has a good margin or not. Thank you.
Thank you. And now Professor Hayashi from Japan is also online. Professor Hayashi, you have some comment on this? Professor Hayashi.
Thank you, Professor Hao. Yeah,
Yes.
I'm looking forward to hear his lecture. So I'm sorry. So I entered just now. So,
okay.
I'm sorry. And so I look forward to hearing Professor Baek's lecture. Thank you very much.
Yeah, so Professor Hayashi, that's the question is about how you take the surgical margins, especially on tongue cancer. You take the margins, you take the samples from the resected tumor, or you take samples from the surgical bed. How's your practice? Yeah, your practice. How you send the surgical margins? Yes.
The procedure of setting surgical margin. So, so I think so evaluation before operation is very important. So we usually use MRI imaging before surgery. So we set the early tongue cancer. We set the surgical margin minimally 10 millimeter to 15 millimeter, and so better. For advanced tongue cancer, we set more surgical margin. So, but I think so the deeper resection margin, the deeper side resection margin is the most important. So we take care of the set. We take care of the setting, the deeper surgical margin carefully.
And thank you. And in my practice, I have some dye for pathology check at my operation room.
Yeah.
And if the case is big and somewhat difficult to make the whole on the peripheral or dim margin, I already stained, but I stained some area, very suspicious area with the dye, and take a picture and send the pathologist, because in Korea it's somewhat difficult to call the pathology doctor to the operating room in practice. So not like you. So
Yes.
send the picture, and we put in the record and send the pathologist to discuss about the numbering, the 1, 2, and 3. And so please, the frozen biopsy report, the tumor is at the peripheral margin at the near numbering 1, or near to number 4, number 3, so we try to make some communication, but not perfect, but that's real in practice.
Yeah. So you mean the staining means iodine staining, iodine staining?
Staining?
Yeah. Do you
Just
mean
just some
intraoperative?
yellow or blue or dye,
Ah.
dye. Dye.
Dye.
Yeah, pathologic dye.
Yeah.
Yeah.
Some doctors use iodine staining.
Iodine is it's for the some not some the to find out the inside or dysplastic lesion. I mean, that's a pathologic frozen sexual specimen. I staining with the margin with the yellow dye or blue dye or red dye.
Yeah, thank you, Professor Chung Hwan Baek, for your wonderful lecture, and also Professor Hayashi and Professor Alfredo Pontejos for your wonderful comment. I think we need to end the section here. So thank you for Professor Baek for supporting me and for supporting this webinar event. So I make some other announcement. Tomorrow we are going to have the 6th, retirement webinar from Turkey. Professor Samuel Shinji, he is a giant in rhinology. He will talk about the fundamentals of rhinoplasty. So for people who are interested in rhinology or rhinoplasty, please, be online tomorrow on time. So thank you again for all your participation, and thank you again for your, wonderful lecture, Professor Baek, and have a good day, everyone here.
Thank you, everybody.
Okay, bye-bye.
Bye.
Bye.
Bye-bye, thank
Thank
you.
you.
Yeah. So I'm sorry, I misunderstood. The next presenter is Professor Baek. So
No problem.
yeah, because
Hope to see you in
yeah.
Japan. Hope to see you in Japan in the Theological Society.
Awesome. See you later.
Okay.
Yeah.
Have a
Bye.
good day.
Have a good day. See you.
Yeah,
You
have a
too.
good day. You
Congratulations.
play golf today, Chung Hwan Baek? You play golf today?
Sorry?
You play
Yeah,
golf today?
Are you playing golf?
Yeah, sure. I will go to the Saint Andrew old course at the 1st of next April.
Oh, okay.
That's
Okay.
my bucket list.
Yeah. Great.
Thank you.
Well,
Old
nice
course,
to enjoy life.
you know old course.
Yeah.
Thank you very much.
Oh, thank you. So have a good day. Bye-bye now.
Bye.
Thank you so much.
Okay,
See you.
bye-bye.
Thank you. Bye-bye. Thank you. Yeah. morning meeting 还有一点时间，开个10分钟。